Good morning, good afternoon. I will be tackling the infections for the school-age child, which I will take to be age 4 and above. So with a K plus 12, you will expect your 4 to 5 year of age children to be entering school. So let me start first with ear infections. So of the diseases that fall under the spectrum of otitis media, 2 will be the one that you will expect to be more common in the school-age population. And this will be your otitis media with effusion and your recurrent acute otitis media. So how often is your otitis media with effusion? In a study that we started last year, this is a longitudinal study in a community, the point prevalence of otitis media with effusion is about 9.5%. So that is particularly high. We don't have yet any statistics for the prevalence of the recurrent acute otitis media, but we do hope to have them soon, okay? So this is your typical otitis media with effusion, okay? You have a very thick fluid behind an intact tympanic membrane. But let me start with recurrent acute otitis media. So how recurrent is recurrent? So if you have 4 infections in a year or 3 infections in 6 months, that is considered recurrent acute otitis media. If your recurrence occurs within the first month after the initial episode, then we term that as early recurrent acute otitis media. Beyond the 1 month, then we just term it recurrent acute otitis media, okay? Now, there have been several risk factors that had been identified with the risk for being an otitis-prone child, okay? So you have several, but the most common and the most important will be the age at which your first episode of an acute otitis media occurred. So the earlier the first episode of your acute otitis media, the more likely your patient is going to get recurrent disease. So if you take a look at this particular picture, if your patient develops your first episode in the first 6 months of life, see, so you have, this is 64, okay? Something like that. 64 will develop another episode in the next coming 6 months, okay? And you have another percentage developing up to 10 years, okay? So again, remember the key. So if you take a look at your 6 to 12 months, again, you will note the number of patients who will be subsequently developing another recurrence. So the key period here is 1 year. So you watch your patients who have their first episode in the first year of life. They are at a risk for being otitis prone, okay? Now, there are a couple of concepts that are important when you want to manage and understand your patient with recurrent disease, and specifically for recurrent acute otitis media. So what can you reasonably expect if you give your patient your antibiotics? So within 2 days, you must have improvement of your symptoms. Now, which symptoms? The redness, okay? The pain and the fever, okay? So those should improve after 2 days of an appropriate antibiotic. Then the patient should be well within the period of your treatment and observation. That will be considered a clinical cure. However, if your patient's symptoms will either persist or deteriorate after 2 days, that is most likely clinical failure. Because remember, in acute otitis media, we're not doing any synthesis, tympanosynthesis. We're just looking at the clinical picture of the patient. Okay? Now, what happens if initially your patient responded to your medication, but then the signs and symptoms came back? Which signs and symptoms? The fever, the pain. Okay? Or the patient was well, but within 4 days after you completed your antibiotic treatment, the symptoms came back, okay? Then, which means otalgia or your fever, then that is most likely a relapse. Note, that is not a recurrence, okay? There must be a distinction. Because in recurrence, all your signs and symptoms will resolve completely. The redness, the pain, the fever, and the fluid, okay? Or the effusion behind your eardrum. Remember, the fluid behind your eardrum does not normally resolve after 2 days. So that's fine. But at the end, you must have complete resolution. Then you'll have a new episode that is recurrence. In contrast to your relapse, your patient never really got well. Okay? All right, so that's clear. Why are we stressing this? Okay? Because there's going to be a difference in the way you're going to manage your patient. Okay? If your signs and symptoms persisted for greater than 2 days, then you treated your patient adequately, then the assumption is that your antibiotic failed to treat your original pathogen. Okay? Now, most of you, the true relapse in acute otitis media will develop within the first 2 weeks that you're treating the patient. Okay? And we do know that in the absence of bacterial eradication, meaning you still have the persistence of your pathogens, either in your nasopharynx or in the middle ear cavity, even if your patient at the end of treatment is clinically asymptomatic, thereby you achieved clinical cure, but there was no bacteriologic cure, chances are your patient will get recurrence. Okay? Next. So, most clinical failures are due to new pathogens, and most recurrence that happen within the first 2 weeks, first 14 days after treatment, are likely to be new infections, and the most likely pathogen is going to be your non-typable H. influenzae. Okay? So early recurrences in general are due to new pathogens, and the most likely are going to be your H. influenzae. Okay? So if you take a look, for example, at a recent meta-analysis that looked at the global etiology of your patients with recurrent acute otitis media, you will notice that patients with recurrent disease and even those with treatment failure are likely to be due to your H. influenzae. Okay? All right, how do you diagnose recurrent acute otitis media? Same as with your acute otitis media, you need to do an otoscopic evaluation, okay? So your normal drum, this is a bulging drum, okay? And you have some exudation, redness of the drum. That will be the one that will most likely correlate with an acute infection. So remember, in recurrent acute infection, you have a recurrent acute otitis media, you have an acute infection. It's just that it keeps on happening, okay? All right. So how do we treat your recurrent acute otitis media? You can treat it as an acute otitis media, but always take into consideration if the patient previously took antibiotics, okay? And you're looking at a timeline of about a month before if there was a previous use of antibiotic within the last month. You can also treat for a longer duration, so rather than 7 days, you can go 10 to 12 days, and you have to actively manage any concurrent nasal problems, okay? Now, what is actually recommended? We are coming out with a handbook on the recommendations for acute otitis media, and in our recommendations, when you have severe disease, defined as having a fever of greater than 38 degrees and having severe pain, then you start with high-dose amoxicillin clavulanate. This is high dose, meaning 90 milligrams per kilo, okay? All right, what are the surgical alternatives? Yeah, gulat, no? Yes, but that is what is coming out in our recommendations. And this is evidence-based, I can hear. So we will, the recommendations are actually going to be published soon, and you will be surprised. This is current evidence-based, okay? Evidence-based recommendations. So we will cite particularly the studies, okay? Now, surgical, okay? Surgical, myringotomy with tube insertion, okay? You've probably heard about this. Unfortunately, the benefits are at the moment unclear. You will see some studies that will say if you put tubes in the ears, it helps. Some studies do not show any clear benefit. So at the moment, recommendation unclear, okay? Next, otitis media with effusion. So what's the difference in your otitis media with effusion? It simply means that your acute signs and symptoms resolved, but you have the persistence of the fluid, okay? It becomes otitis media with effusion if you have the time frame of 3 months. Now, why do you use 3 months? Because the studies show that beyond 3 months, less than 10% of your patients are going to clear their fluid spontaneously, okay? And also, if you take a look, the thicker the fluid will be, such as will happen if you have a long period of time, okay? Then the chances of it resolving spontaneously are going to be very small, okay? These patients are going to be essentially asymptomatic, but they will have some hearing loss, about 25 decibels, okay? Next, okay. Now, this one is pretty clear, okay? Putting tubes, myringotomy, you make a little incision in the drum, you put in the tubes, has been shown to help for otitis media with effusion, okay? So, the tubes stay there for a short period of time, less than a year, and then they are extruded spontaneously by the drum, okay? Now, what is not recommended treatment? Let's start with antimicrobials. Why not? And we're talking about otitis media with effusion. If you take a tympanocentesis of your otitis media with effusion, a lot of them will have a negative culture, okay? If you do a PCR, you would probably be able to get some bacterial DNA, okay? Now, the question is, even if you are able to demonstrate bacterial DNA, that doesn't mean the bacteria was viable. So what does that imply? And also because some of the studies show that there is a significant immune response, okay, generated in your patients with otitis media with effusion. So again, what does that suggest? It suggests that some patients may have had a prolonged and a very robust, okay, immunologic response to a previous infection. Now, whether that is a function of host factors, a function of pathogen factors, or a combination of both is unclear at the moment, okay? Another thing is biofilms have been demonstrated in patients with otitis media with effusion. Therefore, as a general rule, antimicrobials are not recommended, okay? Now, topical systemic corticosteroids, topical or systemic antihistamines, topical or systemic decongestants are not recommended for the treatment of otitis media. However, if you have concomitant, concurrent disease, nasal problems, allergies, go ahead, okay? Because you have to actively manage your nasal problem, okay? Next, rhinosinusitis. So, this is your turbinate and you have the pus, okay, coming out. Okay, how do we define bacterial rhinosinusitis? Okay, acute bacterial rhinosinusitis. It's simply a cold that lasts for more than 10 days, okay? Or you have worsening of what seemed to be a common cold after 5 or 7 days. But I can assure you that if you've had for 3 consecutive days, okay, purulent, foul-smelling discharge, that is most likely already rhinosinusitis, okay? That is beyond rhinitis, okay? Next, all right. Again, it's important for us to understand the pathophysiology of your rhinosinusitis. And you have, in the beginning, number 1, okay, you have edema that causes obstruction, and therefore you cannot drain your secretions. That already elicits the entire cycle that leads to the stagnation of your secretions, the growth of your bacteria, and then you have the irreversible changes that further cause the inflammation and the blockage, and therein goes a vicious cycle, okay? So, the 3 most important things that should be addressed for the sinus to function will be this. And this is going to be important also when you want to manage patients with rhinosinusitis. So what will this be? You must have normal mucociliary clearance, normal quality and quantity of mucus secretion, and you have a patent ostium, okay? Okay, so you start out, most infections of rhinosinusitis will start with a viral infection, but about 5 to 13% of them will go on to develop bacterial disease, okay? And over time, you have the anaerobic bacteria that will eventually is usually associated with your chronic disease, okay? So how do you know it is acute rhinosinusitis? Okay, this is from the European position paper on rhinosinusitis. You should have a sudden onset of 2 or more of the following. But what is important is that one of them must be either nasal congestion or obstruction or nasal discharge. Note, we define nasal discharge as being either anterior drip, posterior drip, okay? Because not all patients will have anterior drip. most of them have posterior drip. The younger the child is, the more likely it is going to be posterior drip. Okay? Next. Okay, so let's do a physical exam again. You have your turbinates, okay? And then your secretions, and then your postnasal drip, okay? So just look at those. Whatever you use, flashlight, otoscope, you got that, you clinch your diagnosis, okay? So, should we ask for any x-rays? No, plain x-rays are not recommended, okay? Why? Okay? In your child greater than 6 years of age, a history will predict positive a positive x-ray 80% of the time. What does that mean? If your history is positive for suspicion of rhinosinusitis, 80% of the time, your x-ray is going to be positive. This is in the child that's greater than 6 years of age, okay? If your patient is less than 6 years of age, the history, 70% of the time, will predict a negative x-ray. What does that mean? If your patient does not have a history that is suggestive of rhinosinusitis, 70% of the time, your x-ray is going to be negative, okay? So you can go with a clinical eye. However, there will be some time when you will need a CT scan. So when you have impending complications, severe disease, immunocompromised patient, then you need a CT scan. Bacteriology, this was a study that Dr. Celia Carlos and I did way back in the year 2000 in children 6 to 12 years of age. As you can see, no pathogen, 11%, probably viral. Majority of them were mixed isolates, and you had 2 pathogens up to 3 pathogens, the most common being strep pneumo and H. influenzae, and you had single isolates in about 25%, okay? So, antibiotic therapy for your acute bacterial rhinosinusitis, your first line for children with uncomplicated, okay, mild to moderate severity without risk factors, amoxicillin clavulanate at 45 milligrams per kilo, going up to as high as 90 milligrams per kilo for your amoxicillin component in the presence of resistance. Again, like acute otitis media, you should expect a response in 48 to 72 hours. How long should you treat? 10 to 14 days. There are no randomized clinical trials that will tell you absolutely, no systematic reviews, no meta-analysis that will tell you for sure that you should treat for this particular duration of period, okay? So, the algorithm for your acute rhinosinusitis in the presence of symptoms less than 5 years of age, baka common colds lang yan, okay? So greater than that, in patients who have moderate disease, you can try oral antibiotics. In patients with severe disease, which is defined as having a fever of greater than 38 degrees and you have severe pain, okay, that will be considered severe. If the patient is toxic, you can try oral antibiotics. And of course, in those who are severely ill, you have to hospitalize them and give them IV antibiotics. At any time, the signs and symptoms of an impending complication occur, hospitalize the patient, and you have to give IV antibiotics, okay? What about chronic rhinosinusitis? It's the same. The only difference is that the duration of your symptoms should be 12 weeks or 3 months. And do get a history of your allergies, okay? So, physical examination is the same. What about imaging? Still not recommended unless you have severe disease, immunocompromised patient, and you have signs of your complication, okay? So, as we said, the 3 functions of your sinuses to be normal, ciliary mechanism, you have very viscid mucus production, and obstruction of your ostia. So, what will be the goals of your treatment? You will restore your mucociliary clearance, restore drainage and ventilation, and restore the patency of your ostium. Excuse me. So, how do we treat chronic rhinosinusitis? You reduce the bacterial load, and you do that by using your antibiotics. You reduce your tissue edema using steroids, and this is either oral or topical, okay? Antihistamines. You reduce your mucus production and viscosity You give mucolytics, and of course, excuse me, if you want to enhance your mucociliary clearance, you do your nasal flushing with your normal saline solution, and you give your decongestants for a short period of time, whether it is systemic or topical, and of course, you remove your inciting factors, okay? Thank you. So what are the surgical ways by which we do address chronic rhinosinusitis? One is adenoidectomy. Then we do very limited functional endoscopic sinus surgery or a combination of both, okay? But there are very stringent criteria for us to do surgery in patients with chronic rhinosinusitis because in general, okay, it is a medical disease in the pediatric population, okay? Next. So this is your algorithm for your chronic rhinosinusitis. You treat the patient for 4 to 6 weeks, okay? If there is no response, and especially if the patient is doing very badly, okay, then you can consider surgery, okay? This is based again on the European paper position paper on rhinosinusitis and nasal polyps, okay? Again, always take note, in patients who have these symptoms, you may be looking at an impending complication, okay? All right, so the last, because I only have like 8 minutes left, okay, recurrent tonsillitis, okay? So again, let's answer the question, how often is recurrent, okay? So you're probably all familiar with what is considered recurrent, okay? 7 infections in 1 year, 5 infections per year for 2 consecutive years, 3 infections per year for 3 consecutive years, okay? But the caveat being that the infections must have been documented. So must have been seen naman by the physician, not merely na sumakit yung throat ng pasyente, may tonsillitis na siya, okay? Second, you must be able to differentiate between viral and bacterial, okay? So when we're looking at recurrent, actually the implication is we are looking at bacterial tonsillitis, okay? Now, you probably will ask the question, why will the patient not respond eventually, okay, to your antibiotics, and therefore you're having recurrent disease? One is because your chronic disease is probably due to overlapping pathogens, okay? So you have overlapping infections with different pathogens. Second, because the bacteria are covered with a very thick inflammatory infiltrate, or they are located inside the macrophages, and they're very difficult to reach. And finally, because in tonsils, as in otitis media with effusion, bacteria have been known to form instead biofilms. So if you take a look at your 4 most common causes of your tonsillitis, which will be your strep pneumo, your H. influenzae, your Moraxella catarrhalis, and your Staph aureus, and your strep pyogenes, okay, you will see that of those 4 have been associated with biofilm formation and have been isolated in your tonsillar tissue, okay? Now, the other thing is, like your otitis media with effusion, sometimes the question is it an infection or an inflammatory disease? Which came first, the chicken or the egg? The infection first and the inflammation, or the inflammation first and the infection, okay? Studies show that high cytokine levels, okay, which is indicative of your inflammatory status, actually cause proliferation of the cells, including your endothelial cells and your fibroblasts, and the result is that you replace your immunologically active tissue with fibrotic tissue, okay? So, if your patients ask you, di ho ba may immune function yan? Apparently, in recurrent tonsillitis, wala na, okay? Then you have your upregulation of inflammatory neutrophilic chemokines, which again induce tissue damage, and possibly impairment of your antigen-presenting activity. So again, the question is it a function of host factors, or a function of pathogen factors, or a combination of both? Currently is unclear, but most likely it is a combination of both. So, having said that, does that mean we will operate on your patient and remove the tonsils? which is normally the question that you ask ENT. All right, in pediatric ENT, there are currently only 2 absolute indications for tonsillectomy, and that will be suspicion of malignancy or, number 1, the presence of obstructive sleep apnea. Okay? Everything else, recurrent tonsillitis, even the presence of rheumatic fever or peritonsillar abscess. Because if you have a peritonsillar abscess, there is a 25% possibility that it will recur. But all of those still fall under relative indications. Okay? So, what does Cochrane review say about tonsillectomy versus non-surgical treatment for chronic or recurrent tonsillitis? Okay, so they reviewed 5 studies, 4 in the pediatric population, 1 in the adults, divided into severe and mild disease, and the results. For severe disease, you will avoid 3 of any severity, including 1 moderate to severe infection within the next year. Okay? In patients with mild disease, you will reduce your episodes from 3 episodes to 2 episodes. The conclusion being that it is effective in reducing the number of episodes, days of sore throat. However, the gain is going to be most marked in those patients with severe disease. Okay? So, in the 3 minutes that I have, I will give my summary. So the most common otitis media diseases in your school children will be your recurrent acute otitis media and otitis media with effusion. You must be able to differentiate between relapse, recurrence, and failure, because your management and your choice of antimicrobials will depend on which condition the patient has. Normal sinus function depends on patency, drainage, normal mucociliary mechanism, and those are the 3 aspects that you will address with your management of rhinosinusitis. And finally, non-response to antibiotic therapy in recurrent tonsillitis is due to biofilm formation, immune dysregulation, and other pathogen adaptations, meaning that your immune function has been totally abrogated, but still it falls under relative indications. So I hope we shared something with you this morning, and thank you very much for your attention.